Hello, my name is André Deneau. I'm a professor of anesthesia and critical care at the University of Montreal. I'd like to thank you for inviting me to present and to share my experience on new development in perioperative brain monitoring. I work at the Montreal Heart Institute as a cardiac anesthesiologist and a critical care physician. This is in Montreal, which will become beautiful in the coming month. My disclosures are shown here, and I'm supported by the Richard Kaufman Endowment Fund in Anesthesia and Critical Care, and also the Montreal Heart Institute Foundation. These are some references that I will discuss during this presentation. I sent the PDF to Mr. Turnbull. These are some of the questions I was asked to cover for this presentation. In terms of the first question, as you will see, the use of DOA as change or hemodynamic management. The second question, in terms of circulatory arrest, we do not have enough data or randomized control trial to answer this question formally, but I will show you how DOA has modified our practice and circulatory arrest. This is the third question. And as you will see, I will show you examples of the link between the NIRS and the EEG. And finally, last question, you will see that indeed we are using it in the ICU. It is useful to detect brain injury, particularly when you combine it with brain ultrasound. And however, in terms of a patient with brain injury, I do not practice anymore in a neuro ICU. So my objective is to appreciate the perioperative role of brain monitoring, to identify the mechanism of brain desaturation using the second generation O3 sensors, and finally to understand our strategy in the use of brain monitoring. So I will discuss initially of our experience at the Heart Institute. I'll go over our published algorithm, and I'll share with you preliminary data on SedLine and outcome. Monitoring comes from the Latin word monere, which means to warn. This is the picture of the Titanic before and after April 15, 1912. The Titanic was the best monitored ship in the Atlantic at that time. On 7 occasions, they were told about iceberg, but they completely ignore it. Similarly, the best monitoring is useless if the user do not listen to the warning and is not familiar with its use. These are our brain monitor at the Montreal Heart Institute. So we have NIRS, we have SedLine or EEG, and also we have transcranial Doppler. In terms of our experience with NIRS, these are some of the work that we have done. These are some of the work that we have published regarding SedLine. On transcranial Doppler, we've written technical article, case reports, algorithm, optic nerve sheet also. And we just started to report our experience with the second generation NIRS. So overall, we've been publishing our experience in more than 2,000 patients. Let's start with near-infrared spectroscopy, which we start using in 2002. In terms of brain oximetry, we know that the baseline values and the intraoperative desaturation correlate with outcome. Brain desaturation correction is possible in the majority of the time. Brain desaturation is, however, non-specific and requires a diagnosis. And you'll have improved brain saturation when your intervention is working. Finally, NIRS interpretation is improved with transcranial Doppler, process EEG, second generation O3, and whole body ultrasound. So how do we manage now brain desaturation? This is the original algorithm we developed. It has 8 steps and is based on combining NIRS to common intraoperative monitors. In 2016, these 2 multi-center studies were published. They asked the question, how often can you correct brain desaturation? The answer was in the majority of patients. In 2010, we start using somatic saturation. So if you have whole body desaturation, you know that the problem is not the brain. In 2019, we published a practical approach on the use of brain and somatic oximetry combined with whole body ultrasound. The algorithm allows you to diagnose 18 different mechanisms of brain and somatic desaturation. The optimal use of cerebral and somatic NIRS requires ultrasound examination, not only the heart, but also the vessels, the lung, the abdomen, and the brain. So we are talking basically of an echo-guided NIRS. The algorithm is the following. You look if you have an artifact. You verify if you have unilateral or bilateral desaturation. And if it's bilateral, is it global or is it regional? In 2015, we introduced continuous transcranial Doppler to monitor cerebral blood flow. 3 bedside modalities can be used to examine and monitor the brain. Those include ophthalmic ultrasound, brain ultrasound, and continuous transcranial Doppler monitoring. Dr. Palermo reported in this article how to perform handheld ophthalmic ultrasound examination. For instance, in severe subarachnoid hemorrhage, vitreous hemorrhage can be seen. This is called a Tierson syndrome and has a prognostic implication. The critical element on transcranial Doppler are the following. Bilateral or unilateral systolic velocity will be influenced by cerebral blood flow, but also global cardiac function. The diastolic velocity, the resistance index, and the pulsatility index also will be influenced by both intracranial and central venous pressure, but also, for instance, by aortic insufficiency. Therefore, when you are having an abnormal transcranial Doppler signal, it is always important to compare it to another Doppler signal from a different organ. High-intensity transient signals are likely to be related to outcome. And finally, the interpretation of transcranial Doppler will also be influenced by NIRS and process EEG. Dr. Couture reported our experience using transcranial Doppler monitoring guided by the use of handheld ultrasound in order to identify the brain acoustic window. This is how to proceed. First, you identify bone landmark. Those include the petrous bone and the sphenoid wing. Then, the cranium, as shown here. Now, you can see the brain, the midbrain in the middle, and the middle cerebral artery to the right. Our experience is that in 95% of patients, you can identify at least one acoustic window to perform transcranial Doppler monitoring. After bypass in some patients, high-intensity transient signal or hits are seen, most likely from air emboli, typically after aortic unclamping. Those emboli can go anywhere, particularly in the right coronary artery, causing myocardial dysfunction. These emboli will go in the right coronary artery territory, which is the basal and the mid-inferior wall, but also the right ventricle. Those air emboli and their consequences are unpredictable. This is a 26-year-old woman undergoing a Ross procedure, and we're unable to wean her from bypass. As we initiate ECMO, there's a lot of hits. And even while she is on ECMO, the number of hits is important. This could explain some of the neurological problems that we see in patients on ECMO. The total number of cerebral emboli captured by transcranial Doppler was 3,538. The patient ended up requiring heart transplantation 2 weeks later. Elevated number of hits are highly prognostic. This is a new version of transcranial Doppler with hits detection. It has a high resolution M mode to identify hits in terms of depth, direction, complexity, energy, and also grade. This modality will enhance reliability in the identification of hits versus artifact. So how do we combine transcranial Doppler and near-infrared spectroscopy? Milan Azam reported our experience on this issue. So if you have new onset brain desaturation and high-intensity transient signal, it's likely to be secondary to RV dysfunction, and you will get global somatic desaturation. Cerebral desaturation with no hits can be due to elevated intracranial pressure or venous congestion. Somatic desaturation will be absent if it's a pure cerebral origin. Finally, if you have new onset brain desaturation, no hits, and a normal TCD signal, those are the possibilities. In 2015, we start using process EEG monitoring. Burst suppression, as shown here, is undesirable. Evidence is growing that it is associated with post-op delirium and brain desaturation if cerebral blood flow is compromised. In collaboration with Dr. Couture and Dr. Deschamps, we reported how we are using NIRS and process EEG. So basically, if you have brain desaturation and increased process EEG, this is typical of awakening, hyperthermia, or seizure. If brain desaturation is associated with reduced NIRS, then the perfusion is compromised. If the somatic NIRS is normal, it is the brain. Otherwise, it is global. Finally, when NIRS is increased, but PEEG is reduced, this is typical of anesthesia induction. Finally, if NIRS is increased and the PEG also increase, those are the possibilities. We will discuss in more detail process EEG later. In 2002, we start using continuous right ventricular pressure waveform monitoring, and this is very useful to detect instantaneously RV dysfunction, which is often associated with hits. Finally, since last year, we are exploring the potential role of second-generation oximetry monitoring that allow the detection of change in oxy and deoxyhemoglobin. We will also discuss this modality in greater detail. I was recruited at the Art Institute in 1999 with my colleague Pierre Couture to develop the TE program. In 2014, we started developing extracardiac TEE for the lung and also the abdomen. We were particularly interested to explore the importance of portal pulsatility, which led to those publications. In this review article reported this year, we describe how regional oximetry values are obtained. The final value is the result of the proportion of oxygenated hemoglobin over total hemoglobin, which is the sum of both oxygenated and deoxygenated hemoglobin combined. The relationship between the absorption coefficient and the wavelength of the infrared absorption of oxygenated and deoxygenated hemoglobin are shown here. Because the absorption is different, then they can be respectively identified and displayed on second generation NIRS O3 monitor. A normal cerebral NIRS indicates a balance between cerebral oxygen consumption and cerebral blood flow. Both variables are influenced by those factors. Brain desaturation results from an imbalance between those factors, arising from increase in cerebral metabolism and decrease in cerebral blood flow. Elevation of NIRS is what we see in the majority of patients following the induction of anesthesia. The delta CHB is a measure of the total hemoglobin, which is the sum of the delta oxyhemoglobin, a measure of relative change in oxygen hemoglobin affected by those factors, and the delta deoxyhemoglobin, which is a measure of the relative change in deoxyhemoglobin, which is mainly influenced also by those factors. In other words, NIRS value will depend on the relative balance between those values. These elements help the clinician in the determination of the cause of brain desaturation. When using brain monitor, always remember the 5 very important factors that will affect brain saturation: cerebral blood flow, oxygen saturation, hemoglobin, oxygen consumption or cerebral metabolic rate of oxygen, and finally, carbon dioxide. All those elements are interrelated, and the final number you see is often a result of a single or a combination of those factors. Cerebral blood flow, which is determined by your cardiac output from your heart, but also influenced by the venous return of blood from the brain to the heart. Therefore, there is an arterial, but also a venous component. I use transcranial Doppler in the operating room to monitor cerebral perfusion. This is an example from a patient in which we have used NIRS and transcranial Doppler. At baseline, this is a transcranial Doppler value with a peak systolic velocity of 53 centimeters per second. As cerebral blood flow is reduced at the beginning of cardiopulmonary bypass, brain saturation and oxyhemoglobin goes down, and the transcranial Doppler also goes down because the cerebral blood flow is reduced. This is a patient with severe mitral regurgitation seen on 3D transesophageal echocardiography. This patient had a previous mitral valve prosthesis and will undergo a percutaneous mitral valve. Brain desaturation appears at the beginning of the procedure shortly. This is secondary to ventricular arrhythmias. Note the rapid reduction in oxyhemoglobin, and a bit later, you have the same phenomenon occurs again. Brain saturation is secondary to reduced cerebral blood flow from the ventricular arrhythmia. Note the simultaneous reduction of both oxyhemoglobin and also the total hemoglobin in those two cases. This is another example of brain desaturation that we often see upon initiation of cardiopulmonary bypass. Note again the reduction of both the oxy and the total hemoglobin and the minimal change in the deoxyhemoglobin. A second episode of brain desaturation appears shortly after. However, in this case, it was associated with an increase in the deoxy and an increase in the total hemoglobin. This occurred because there was an accidental clamping of both the aorta and the superior vena cava, which, if unrecognized, could lead to a superior vena cava syndrome. Patients with superior vena cava will develop upper airway and facial edema, and also intracranial venous hypertension that you can diagnose at the bedside by measuring the optic nerve sheath. In addition, the transcranial Doppler velocities will also demonstrate the typical sign of elevated intracranial pressure, which is reduced diastolic velocities and increased pulsatility index. Medical and surgical interventions that improve cardiac function will also improve cerebral blood flow and brain saturation. This is the hemodynamic waveform in the operating room. In red and in pink, you have the femoral and the radial artery pressure. In yellow and in green, you have the pulmonary and the right ventricular pressure. Note that the pulmonary artery pressure of 85 is much more than what we were expecting in this patient. And this was associated with a significant reduction in brain saturation. Remember that the normal value should be more than 60. These are the hemodynamic waveforms 18 minutes later. The pulmonary artery pressure scale was readjusted because the PA pressure went from 86 to 30 millimeter of mercury. The arterial pressure did not change. And a significant increase in brain saturation occurs, which indicates the efficacy of the intervention. Oxygen that we can measure non-invasively with pulse oximetry will directly correlate with brain saturation and oxyhemoglobin. The use of single lung ventilation was associated in this patient with brain desaturation. Note the reduction in the oxyhemoglobin, increase in the deoxy, and no change in the total hemoglobin. This was associated with systemic desaturation. If the cause of systemic desaturation is unclear, then lung ultrasound should be performed. Hemoglobin is our third component. It will significantly influence baseline brain saturation, but also will correlate directly with its change. Oxygen consumption, or cerebral metabolic rate of oxygen, CMRO2, will determine how much oxygen is required. For instance, brain saturation can be normal with no flow from the brain. This is what we see in the operating room during hypothermic circulatory arrest in the beginning. The hypothermia will reduce the oxygen consumption. This is the electrical activity of a patient waking up at the end of the procedure. On the DSA, you can notice that there is bilateral increase in spectral edge frequency compatible with emergence from anesthesia. On the NIRS monitor, bilateral brain desaturation is present. And when you look at the component with an increase in the deoxyhemoglobin over the oxyhemoglobin, this is not a dangerous brain desaturation that would be associated with brain hypoperfusion. The process EEG is, in this case, the clue for the diagnosis of brain desaturation. Finally, carbon dioxide is very important. Reduced carbon dioxide will vasoconstrict the brain vessels and reduce cerebral blood flow. When we start using NIRS in 2002, iatrogenic hypocapnia was the cause of 1/3 of all our brain desaturation. I will now give you an example when we combine all this information. This is a 57-year-old woman undergoing a Ross procedure during bypass. Note that there is a significant reduction in the oxyhemoglobin and total hemoglobin. In this patient, transcranial velocities are elevated even more than 200%. There is even burst suppression. The PO2, the PCO2, and the mean arterial blood pressure are normal, but the increase in cerebral blood flow, the burst suppression, and the reduction of temperature should increase the NIRS value. However, this patient had anemia. So the discrepancy between the NIRS and the oxyhemoglobin is explained by opposing factor. And this patient has a normal compensated brain saturation. So this is how we use this new information. Brain desaturation with a stable oxyhemoglobin, but an increase in both the total and the deoxyhemoglobin is typical of cerebral venous congestion, such as the superior vena cava syndrome. If brain desaturation is associated with a decrease in the oxyhemoglobin, a stable total, and an increase in the deoxyhemoglobin, this is what we saw in patients who have an increased oxygen consumption or a decrease in oxygen content, such as during awakening and hypoxemia. If brain desaturation is associated with a decrease in both the oxy and the total hemoglobin and a stable deoxyhemoglobin, this is typical of reduction in cerebral blood flow as we see in cardiopulmonary bypass initiation. And finally, you can have combined mechanism, such as when you have biventricular failure. Normal brain saturation associated with a reduction in the oxy and the total hemoglobin indicates a compensated normal brain saturation that we could see, for instance, in anemia and hypothermia. Finally, a normal brain saturation should have normal parameters. However, if a patient has normal cerebral and somatic saturation, but he is hypotensive, always think about a pseudo-radial hypotension. This condition is probably more serious and more common than we think. Clinically significant radial to femoral gradient, systolic more than 25 or mean above 10, have been reported to occur in up to 1/3 of cardiac surgical patients. This is a recent prospective study in PRESS in which we quantified the radial to femoral pressure gradient in cardiac surgery. It was present in 35% and lasts about 1 hour. Brain oximetry can be used to suspect such a gradient. Another pitfall or maybe usefulness of using NIRS is the following. This is a 60-year-old man undergoing coronary revascularization, and this is the femoral and the radial artery pressure before bypass. Note that the brain saturation is completely normal. During bypass, a significant gradient appears between the femoral and the radial artery pressure. Brain saturation remains normal despite a mean radial artery pressure of 29 mm of mercury. Transcranial Doppler is also normal during that episode. These are the hemodynamic data during surgery. During bypass, this is the evolution of the femoral artery pressure and the radial artery pressure. The use of a radial artery pressure alone can lead to unnecessary utilization of vasopressors and possibly iatrogenic maintenance of a radial to femoral gradient after bypass. Brain oximetry is therefore very useful to suspect such a gradient if you rely only on a radial artery pressure monitoring. Those gradients can be present not only during bypass. The role of a process EEG is to monitor the depth of anesthesia and to detect awareness or awakening, which is quite rare compared to the detection of excessive anesthesia. Process EEG is an indirect brain perfusion monitor. I'll show you some example, but also a vasoactive agent monitor. This is the SedLine display. You can see the 4 EEG channels. Process EEG gives a patient state index, or PSI, which is a composite index that takes into account several parameters to give an idea of the state of arousal of the patient to the clinician. On the DSA, you can get other elements, such as the spectral edge frequency, burst suppression, and burst suppression ratio. When we install the monitor, we use the back of an open 10 cc syringe or a Venturi mask oxygen adapter to press around the electrode. Do not press directly in the middle. You may dissipate the gel and increase the impedance. A good signal should be displayed as green with reduced impedance. The digital spectral array has 3 components on a 3-dimension. Frequency on the x-axis from 0 to 30 Hz, the power or the relative importance of each brain frequency, and the time. Counterclockwise rotation of the 3D figure and transformation to a 2D image will now show the frequency and the power on the y-axis and the time on the x-axis. This is a typical signal, and you have on the left side, and this is the mirror image on the right side. You have the beta frequency are shown here, the alpha, the theta, and the delta frequency. The spectral edge frequency, or the SEF, is defined as the frequency under which 95% of the EEG power is located. It basically corresponds to the white line. We will typically aim at a value of 15 or less during general anesthesia. This is an example from a 71-year-old man undergoing percutaneous atrial septal defect closure. Following the induction of anesthesia, NIRS value increases. Simultaneously, the electrical activity is reduced on the process EEG. When looking at the component of the NIRS signal in detail, we observe an increase in the oxyhemoglobin, a reduction in the deoxyhemoglobin, and minimal change in total hemoglobin. Burst suppression is defined as an alternance between isoelectrical activity and high frequency and high amplitude. It is absent during normal sleep, and it is definitively pathological, seen in excessive anesthesia, cerebral hypoxia, or hypothermia. We can quantify burst suppression. In this example, the burst suppression ratio is 12. This indicates that over the last minute, burst suppression was present 12% of the time. Burst suppression as a result of excessive sedation can be associated or not with various degrees of brain desaturation. This is a 78-year-old man undergoing percutaneous atrial septal defect closure. Burst suppression appeared after the administration of 20 mg of propofol. It was associated with mild reduction in brain saturation from hypotension. Burst suppression reappeared a second time after 10 mg of propofol, but minimal desaturation was observed. This is our preliminary retrospective experience using SedLine. 150 patients before SedLine were compared with 150 patients after. In terms of demographic data, the SedLine group was older, but there was no difference in terms of Euro score and New York Heart Association. Mild pulmonary hypertension was more common in the SedLine group, but there was no difference in terms of severe pulmonary hypertension. There was no significant difference in terms of procedures except more congenital surgery before SedLine. The use of SedLine was associated with reduction in the use of isoflurane, propofol, fentanyl, noradrenaline, but an increase in the use of nitroglycerin. In terms of intraoperative outcome, the use of SedLine was associated with reduced intraoperative fluid balance, easier weaning from bypass, and reduced blood losses. In terms of postoperative outcome, the use of SedLine was associated with reduced duration of mechanical ventilation, no change in delirium, but reduced vasoactive inotropic score upon admission in the intensive care unit. This is a 69-year-old man with aortic stenosis and aortic dilatation. During the circulatory arrest, you can notice on the DSA the absence of electrical activity. Despite the absence of flow, there was no significant brain desaturation. This is my personal and limited experience with circulatory arrest in 94 patients since 1999. Since the introduction of SedLine in those cases, I observed more frequent easy separation from bypass. This means there's no inotropes and no medication or just vasopressors. I also noted that the duration of intubation less or equal to 4 hours was also more frequent after the introduction of SedLine. But one of the most useful aspects is the timing in terms of reactivation of anesthesia agents after the circulatory arrest, which is now based on process EEG activity. This is an example of a 56-year-old man with the aortic dissection. You can see the aortic hematoma. Circulatory arrest was induced in this patient. Note the brain desaturation following the 24-minute circulatory arrest. But at 18:05, there is still burst suppression, and only 11 minutes later, electrical activity appears. We then restarted the anesthesia. So this time period is extremely variable between patients. However, our ability to avoid burst suppression could explain why patients wake up earlier now than before after circulatory arrest. This group, led by Pedemonte from Boston, confirmed the importance of burst suppression. In a recent retrospective study of 141 cardiac surgical patients older than 60 years old, the author analyzed those factors. They observed that there was 5 variables associated with delirium. The first 3 were directly associated with burst suppression and delirium, and age was an independent factor of delirium. Cochrane Library now states that the use of process EEG to monitor and control depth of anesthesia reduces the incidence of postoperative delirium. Sometimes the intraoperative cardiac arrest is not planned, and this is what can happen. This is a 68-year-old woman who's undergoing her third aortic valve replacement. She has a cardiac arrest. Note that just prior to the arrest, there is a progressive reduction in the spectral light frequency, then isoelectric activity, which was followed by this very abnormal DSA signal. Unfortunately, the patient did not survive. So how can you interpret burst suppression without knowing if brain perfusion is appropriate? So the question is, what do you trust to adjust your anesthesia? Expired gas and MAC from the lung, or EEG activity from the brain? In our institution, many of us have switched to the brain. Is there any impact of this strategy? This is an example of an 85-year-old man undergoing MitraClip procedure for severe mitral regurgitation. His baseline value is 50 on both sides. His cerebral blood flow is normal. The TCD value from the middle cerebral artery are normal at the beginning of the case. However, this patient has elevated central venous pressure and the optic nerve sheath is enlarged, so there could be some degree of venous congestion. His oxygenation is normal, but he is anemic. His oxygen consumption is reduced and his PCO2 is slightly elevated. So these three elements should raise the value and could explain why there was an increase in total hemoglobin. But the cerebral venous congestion and anemia would reduce it, the net result being a pseudonormal stable value. Initially, the anesthesia consisted of sevoflurane 0.8, remifentanil, and propofol. The MAC was 0.5. However, the process EEG, in this patient, there was burst suppression. There was normal NIRS, normal blood pressure, and a normal transcranial Doppler. So, and about an hour later, after reducing the sevoflurane, the MAC is 0.2, but the process EEG is normal. The NIRS increased despite even lower blood pressure and transcranial Doppler values. A recent clinical trial from Australia that included 655 at-risk patients undergoing major surgery from 8 centers in 3 countries concluded that the incidence of post-op delirium in the BIS 50 group was 19% and in the BIS 35 group was 28%. At 1 year, those in the BIS 50 demonstrated significant better cognitive function than those in the BIS 35 group. Interestingly, inotropes use was lower in the BIS 50, and also the time of burst suppression was also shorter in that group. In our ICU, we use both NIRS and process EEG. The application of cerebral monitoring in the ICU consists of brain and somatic oximetry for perfusion monitor, ECMO, detection of pseudo-radial hypotension, but also process EEG to detect burst suppression, seizures, and non-convulsive status epilepticus. And we also combine those with whole-body ultrasound. Let me tell you about a case that happened while I was on call in February 10th of this year. This was a 76-year-old woman after aortic valve replacement. She had initially bleeding and then it stopped, and then her vasoactive support increased. The lactate was increasing at 6, and there was a suspicion of cardiac tamponade, so she might have required reoperation. I would like to remind you that in February in Montreal, it's pretty cold. Montreal is in a white dress. Fortunately, I have a garage for my car. It's beautiful outside, but for a man like me with a beer, that can be a challenge. When we brought back this patient who was in shock after cardiac surgery in the operating room, the baseline brain saturation was 55 on the left and 49 on the right. The normal values are typically above 60. The potential causes of brain desaturation were the following. However, in this patient, it was secondary to reduced cerebral blood flow from the shock state, but also anemia with an hemoglobin of 87 grams per liter. All the other elements were normal. This is a mid-esophageal four-chamber transesophageal echocardiographic view of the heart with the left and the right atrium. In this case, the cerebral blood flow was reduced from a reduction in cardiac output, but because of the right atrial compression from the tamponade, there was also cerebral venous congestion. Following drainage, look at how bigger is the right atrium. So brain saturation increased, oxyhemoglobin improved because the cardiac output and cerebral blood flow to the brain increased, and the deoxyhemoglobin was reduced because the venous drainage of the brain was also improved. Patient was extubated shortly, postoperatively, and home 2 days later. This is a 74-year-old woman post-op day 4 after aortic and mitral valve replacement. This patient had biventricular dysfunction, chronic renal failure, and severe atheromatous disease. And she was found hemodynamically unstable in the ICU on the 4th day at 2 in the morning with elevated lactate. This is the combined SedLine and NIRS monitor in the ICU. At one point, there was significant reduction in brain desaturation. This was not associated with any change in EKG, saturation, hemoglobin, and PCO2. So why? In this patient, we observed that there were no change in total hemoglobin. This indicates that brain desaturation is unlikely to be related to blood loss or an hemorrhagic shock. There was an increase in the deoxyhemoglobin and a significant reduction in the oxyhemoglobin. From our preliminary experience with this monitor, this is highly suggestive of cardiac dysfunction. But why? We performed a TEE and it confirmed biventricular dysfunction with an enlarged inferior vena cava. But when you look carefully in the liver, not limiting the TEE exam just to the heart, air was present in the portal vein and in the liver. This is suggestive of mesenteric ischemia. Unfortunately, this patient did not make it, and the autopsy confirmed our suspicion. This patient basically developed an acute cardiointestinal syndrome with myocardial depression. In a recent article in Anesthesiology on the management of ECMO for post-cardiotomy cardiogenic shock, those are the complications associated with ECMO and the monitoring tools. Note the use of cerebral and somatic NIRS. ECMO patients are routinely monitored with cerebral and somatic NIRS in our institution. Regional limb desaturation confirmed in physical examination was the result of a DVT that was extending into the inferior vena cava. And in this patient, the desaturation improved following the use of anticoagulation. In sedated patients in ICU, we commonly observe burst suppression, which just goes away when we stop the medication and readjust the sedative agents. This burst suppression is almost always associated with vasoplegia, which also is reduced when you adjust your sedative agents. Process EG will even be recommended for ECMO. This is a patient transferred to the operating room. When we installed the process EG, there was already burst suppression. Structural brain disease will alter the process EEG. This patient has a left side stroke. Note the process EEG asymmetry and also the enlarged optic nerve sheath and also portal pulsatility, which also contribute to cerebral venous congestion. Sudden loss of the SUD-line signal in the ICU in a 47-year-old woman on ECMO. A CT scan was obtained and showed severe cerebral edema. Enlarged optic nerve sheath was also present in this patient. This article published in 2008 is on the significance of burst suppression in the intensive care unit. They use process EEG on 125 mechanically ventilated patients. In blue and in red are those with or without burst suppression. On the y-axis, the mortality. An association with burst suppression and mortality was observed. In the ICU, you can use process EEG to monitor for seizure. This is an example of a unilateral seizure on the left frontal cortex. The other side is normal, and the seizure just goes away after intravenous benzodiazepine. In the ICU, you can also see bilateral seizure activities that are resolving after treatment, or this is an example of generalized seizure. If we summarize the algorithm, whenever you have unilateral brain desaturation, always position the head, look at the carotid, the optic nerve sheath, and use transcranial Doppler to examine the cerebral arteries. If it's unilateral upper or lower extremity, you will want to examine the peripheral artery in the vein and also the inferior vena cava. Whenever you have pure cerebral brain desaturation, this is when you're going to use the component, for instance, to diagnose cerebral venous congestion. But basically, look at these 5 factors that we've discussed, and always consider repositioning the head, because this is something very simple to do and associated with some degree of success if it's the cause. If you have head and upper extremity, it's a superior vena cava syndrome. If it's the head and the lower extremity, it's an inferior vena cava syndrome. Whenever you have global brain desaturation, you want to look at the heart, the right ventricular and the central venous pressure wave form. You will get an hemoglobin. You will also use ultrasound to look at the lung and the abdomen. And if you have transcranial Doppler and lots of hits, that would suggest right ventricular dysfunction. Finally, you can have patients who are unstable, but brain saturation and somatic is completely normal. And I would call this a mismatch between saturation and the clinical condition of the patient. So is this patient unstable or not? So if the patient is stable, always remember that that could be a pseudo-radial artery hypotension. It can also be secondary to burst suppression from excessive anesthesia agents, but also remember that a distributive shock with a high cardiac output can also present in such a way. In those patients, you will use extracardiac ultrasound and TE examination to determine the etiology. So when we take care of our patients, having 2 hands is pretty useful. On one side, you have the monitor. Again, comes from the word monere, which means warning. Burst suppression or brain desaturation are problems. However, the monitor does not tell you why. Bedside ultrasound will tell you what is the problem or problems, but bedside ultrasound is a poor monitor. There are no alarms, and you cannot use it continuously. You really need both. So in summary, brain monitoring is an essential part of our practice at the Montreal Heart Institute now for 21 years. cerebral NIRS? Answer the question, is brain oxygen delivery adequate? Somatic NIRS? Is whole body oxygen delivery adequate? These chromophores are helpful in telling you what is the mechanism of a change in NIRS. With SEDLine, I'm answering the question, am I giving adequate amount of anesthesia? And finally, if NIRS or SEDLine are abnormal, the impact of this monitor is based on our ability to find and correct the etiology at the bedside with the other monitors and also with whole body ultrasound. This presentation would not have been possible without my research teams and my collaborators, and also my colleague from the Montreal Heart Institute. Thank you for your attention.